Domestic cats are the only definitive hosts for Toxoplasma gondii. While many animals can carry the parasite, the entire reproductive cycle depends on this host. The sexual phase of the parasite, known as gamogony, occurs exclusively within the feline intestine. This process produces the progeny that will eventually leave the host to infect others. The first parasitic form is the oocyst. Shed in feline feces, its resilient wall allows it to survive harsh conditions for months. Human infection occurs through accidental ingestion, typically from unwashed vegetables, unfiltered water, or poor hand hygiene after gardening. Cats shed millions of oocysts, turning the environment into a persistent reservoir for the parasite. This facilitates its spread to a wide range of intermediate hosts. A second, distinct route of transmission is foodborne, occurring through the consumption of intermediate hosts like sheep, pigs, or cattle. In animals, a parasite forms tissue cysts containing slow-growing bradyzoids, persisting in muscle and brain tissue. Humans are infected by eating this undercooked meat, directly ingesting embedded parasites. Clinically, meat ingestion means cyst infection, while soil or water exposure involves oocysts. Differentiating these forms is more than a biological exercise. It allows clinicians to trace the specific environmental or dietary exposure leading to the patient's infection. In healthy adults, the immune system typically contains the infection quickly. The process is often asymptomatic or results in mild flu-like symptoms before the parasite enters a dormant cyst stage. The clinical focus shifts when a seronegative woman contracts a primary infection during pregnancy. Without pre-existing antibodies, the parasite can disseminate freely. This phase is driven by tachyzoids. These are the fast-multiplying, crescent-shaped forms seen here, which circulate in the blood, and possess the ability to cross the placental barrier to infect the fetus. The timing of this transmission determines the severity of congenital toxoplasmosis. Infections in the first trimester are less frequent, but often lead to severe outcomes, like hydrocephalus or fetal death. Conversely, third trimester transmission is more common, but may only manifest as ocular lesions later in the child's life. During pregnancy, the parasite transitions from a dormant state into a systemic, mobile phase that targets fetal tissues through the action of tachyzoids. Diagnosing a recent infection is complex. A positive IgM test is often misinterpreted as proof of a new infection, but the biology of the antibody suggests otherwise. While IgM appears early, it can persist in the blood for months or even years after the initial exposure. Relying on its presence alone can lead to an incorrect assumption of recent infection. To more accurately date the exposure, labs measure IgG avidity. Low avidity indicates a weak bond between the antibody and the parasite, characteristic of a recent infection. High avidity confirms an older, established immune response. If a maternal infection is confirmed, the next step is determining if the fetus is infected. This requires a PCR test on the amniotic fluid to detect the specific DNA of the parasite. At birth, a baby's blood will naturally contain maternal IgG antibodies, as these small proteins cross the placenta freely. To prove a congenital infection, doctors must find evidence that the infant is producing its own antibodies, specifically IgM or IgA, using the ISAGA technique. Accurate management depends on distinguishing between the mother's historical immune markers and the baby's active response to the parasite. The final high-risk group includes patients with severe immunodeficiency, particularly those with AIDS and a CD4 count below 200 cells per microliter. In these patients, the danger is rarely a new infection from the environment. Instead, the complete loss of immune surveillance allows dormant tissue cysts already present in the brain to reactivate. The slow-growing bradyzoids revert into destructive tachyzoids. As they multiply and rupture host cells, they cause localized inflammation and necrosis, leading to toxoplasmatic encephalitis. Clinical presentation typically includes fever, headache, and focal neurological deficits. If left untreated, the condition can progress to seizures or coma. In the context of advanced HIV, the clinical challenge is not preventing a new exposure, but managing the endogenous reactivation of a parasite acquired years earlier. Summarizing the forms and their roles, oocysts are the environmental stage linked to cats. Tissue cysts are the dormant stage found in meat, and tachyzoites are the active, spreading stage that crosses the placenta or invades the brain. These biological stages dictate the diagnostic approach. We use IgG avidity to date the infection, PCR on amniotic fluid for fetal diagnosis, and the ISAGA technique for neonatal screening. Prevention relies on breaking these transmission chains, cooking meat to safe temperatures, washing all produce, and maintaining monthly serological screening for non-immune pregnant women. The pathogenicity of Toxoplasma gondii is inextricably linked to the immune status of its host. Understanding these specific biological transitions is the key to effective clinical intervention.